Hi, I'm Dr. Clifford Singer. I'm the Chief of Geriatric Neuropsychiatry at Northern Light Acadia Hospital in Bangor, Maine. And I'm going to follow up where Dr. BA left off and talk with you about treatment. Treatment really begins with prevention. Increasingly, there is a focus on maintaining brain health throughout life. The Federal Center for Disease Control has a program called the Healthy Brain Initiative, which takes advantage of all of our expanding knowledge and resilience factors for cognitive decline in old age. And I love this graphic of from the Lancet of risk factors for cognitive decline and dementia throughout life, looking at both potentially non-modifiable, realistically at present, non-modifiable genetic risk factors, and all the lifestyle and personal health uh, risk factors at different stages of life, beginning with genomic risks. The main one for Alzheimer's disease and other neurologic diseases is the ApoE4 allele, and one or two copies of this allele increases your risk of Alzheimer's disease um, by doubling with one risk, with one allele, and essentially tripling or quadrupling risk when when you're homozygote with the ApoE4 allele. Starting in early life, there are potentially modifiable risk factors, including a healthy childhood with robust early childhood education and avoidance of head injuries and malnutrition and other risk factors in childhood for emotional and cognitive disorders. In midlife, hearing loss, hypertension, and obesity are significant risk factors. And then in late life, smoking, depression, physical inactivity, social isolation, diabetes. I should put poor oral hygiene in this list as well, because increasingly that's recognized as a risk factor as well. So a population health perspective is really becoming one of our responsibilities for patient well-being into late life. Looking at components of a treatment plan at different stages of cognitive decline, let's look at throughout all of adulthood. There's we like to do counseling for healthy brain aging and provide a prescription for patients that include using a helmet for physical activities where there's risk of head injury, physical activity. We know that I'm sure many of you counsel 150 minutes of vigorous physical activity a week. That's 20 minutes, a little over 20 minutes a day, or 30 minutes 5 days a week. But there's good evidence that any amount of physical activity is better than none. Moderate alcohol intake, sleeping 7 to 9 hours on average. We know that very short sleep is a risk for Alzheimer's disease, and very long sleep is a risk for cognitive decline, probably because of its association with cardiovascular disease, obstructive sleep apnea, and other things. Stress reduction is important. A Mediterranean diet, or at least a diet, a plant-based diet with that minimizes red meat is good. There are many, I think, diets worldwide that might promote brain health through life. It's just that we have the most evidence for the Mediterranean diet. And I'm not sure if that means just whether an Italian diet or Greek diet, a Lebanese diet or Moroccan diet, which one is better. They all share certain elements of minimal red meat, lots of olive oil, and lots of fruits and vegetables. Good oral health, as I mentioned, we know that oral health or poor oral health is a risk factor, perhaps for Alzheimer's disease, and that social engagement, social isolation is said to be as much a risk factor for cardiovascular disease and cognitive decline as diabetes and hypertension. Those data sets are compelling to a degree. They're not of the highest quality, but there are many studies to support the notion that social isolation is bad for your health at many levels. So these are all preventive measures. And we know, or I should say it's been calculated, that if you can delay the onset of symptoms of cognitive decline, you can prevent as many as 50% of cases of dementia from Alzheimer's disease. And of course, that's because risk for dementia and Alzheimer's disease is age-related. And as people live longer without cognitive decline, they're at higher risk for death from cancer, heart disease, and other non-dementia related, non-brain related problems. Let's look at a treatment plan for mild cognitive impairment, sometimes called prodromal dementia or prodromal Alzheimer's disease, depending on the underlying pathology. The earliest symptoms of cognitive decline, Dr. B.A. spoke about this, mild cognitive impairment. Sometimes it's stable, but it is a significant risk factor for progression. And because of that, although people may be fully independent in functioning at the earliest stages of MCI, they need some oversight for when their cognition does decline, if it does. But they are at high risk, so oversight of driving safety, oversight of finances, since MCI is a significant risk factor for financial scamming. So oversight of finances, oversight of medication management, optimal treatment of comorbid conditions which affect brain function, and most comorbid conditions do. And then, of course, consideration for clinical trials. There's a lot of effort focused on finding potential treatments at the MCI stage that can delay cognitive decline. There's also a lot of discovery work going on, many studies recruiting people with mild cognitive impairment to define the genotypes and the phenotypes of patients with this condition that might predict progression, that will open up in the future opportunities for interventions to slow or prevent cognitive decline. But if MCI does progress to early dementia, people can be counseled to follow all these other things that are above. But this is a time to consider prescribing a cholinesterase inhibitor to support brain function. It's a time for caregiver and family education about prognosis and perhaps family risk for themselves. And then also a good time to consider referral to the Alzheimer's Association or your area agency on aging if people are going to need more support and education regarding living with a person with early dementia. At the moderate stage, you might consider adding memantine to the cholinesterase inhibitor. At this stage, people will need more support for their activities of daily living. Their caregiver is likely to be starting to experience some feelings of being overwhelmed or just fatigued about care responsibilities, or maybe just fearful about the future now that the present is becoming all too aware of the impact of that dementia can have on their lives. Might be a time for many people, most, to give up driving. This is a challenge, and there are many educational opportunities for you to help you have that discussion with your patients. The requirements or the recommendations for reporting people with cognitive impairment to the Motor Vehicle Bureau vary from state to state. Some states you're mandated to report suspicion of impairment. Others leave it up to your clinical discretion. So you have to understand what that means, in what the regulations are in your state. Also, this could be a time to have an advanced directives discussion with the patient. Most people at this stage still have several years of life left. and some of those years can be productive and happy, but their world is contracting, and then illnesses will take more of a toll, and surgery will take more of a toll on brain function than it would have at earlier stages. So it's worth having a discussion about what's important, what's the bottom line for quality of life for that person, and what, while they can still participate in this discussion, let them express themselves and express their wishes. If in the future, hopefully distant future, but if in the future they can't advocate for themselves. At the late stage, there may be a modification of advanced directives to limit intrusive interventions, life-saving interventions, certainly critical care interventions. People will need increasing support for ADLs, likely from other family members or professional caregivers, home care. They may need families and patient might need to start thinking about transition to supportive care environments, memory care, assisted living, residential care, and then as these diseases progress and basic functions are compromised, like mobility, walking, swallowing, then nursing home, long-term care. And then finally, making people aware of palliative and hospice care options in your area. Increasingly, dementia is recognized as an important reason to refer advanced dementia as a reason to refer to palliative care and dementia. It's usually only done at the very end stage within the last week or two of life, but referrals can be made certainly sooner than that. This is a person-centered, focused dementia care, elements of good dementia care provided on the Alzheimer's Association website. And the elements include detection and diagnosis, which by this point you've already done, assessment of cognition and care planning around cognitive decline, medical management of comorbid conditions, including mental health problems, depression, anxiety, and hallucinations or delusions if they develop, information, education, and support for family members, home care staffing or consideration for transferring a person to structured therapeutic environment for safety, transitions and coordination of care between home, hospital, residential, or assisted living. Dementia management quality measures have been published by several professional organizations. Clinical practice guidelines have been established, and I just want to review some of the basics in this area and the settings in which they're most appropriate. So disclosure of a dementia diagnosis, certainly appropriate on the outpatient service, and perhaps in post-acute care. I'm less excited about doing it on an inpatient basis just because in the hospital, people are probably suffering from an acute medical problem or post-operative delirium. So it's not always, we're not always accurate in assessing the presence of dementia or certainly the severity of it on an inpatient setting. But of course, some people are admitted specifically because they can't function independently, and dementia is the primary reason they're in the hospital. So certainly in that setting, it may be the first time that dementia is recognized. That could be a setting where the disclosure of diagnosis is appropriate. Education and support of caregivers for patients with dementia, I think that certainly applies to all care settings, here just outpatient and post-acute care. But I can see that being important in the emergency department and inpatient setting as well. Functional status for patients with dementia, meaning establishing with the family what a person can and can't do for themselves. Perhaps an occupational therapist or a physical therapist can be, or nursing can be helpful, certainly with educating family members and patients around this. Screening for management of behavioral symptoms associated with dementia, appropriate in all care settings, especially because these symptoms frequently lead to hospitalizations or emergency department visits. The same with safety concerns, certainly something to focus on in all care settings. Driving safety in the outpatient setting, and I think by the time people get to post-acute care, unless they've had an acute hospitalization and are there for skilled nursing, I don't see that being a topic for post-acute care, nursing home, or assisted living. Usually they've given up driving by then. Advanced care planning and palliative care counseling, certainly for all settings. Pain assessment, the same. People with dementia generally get less analgesic. One study, 50% less analgesic medication than people without cognitive impairment, just because they're not as likely to report pain, but do so behaviorally and not non-specific behaviors, calling out, agitation, restlessness, and so forth. So assessing pain with some validated instruments for physical discomfort and pain in people with dementia is reasonable in all care settings. And then pharmacologic treatment for dementia, meaning cholinesterase inhibitors, memantine, and psychotropic medications.